So Tripp, can you point to a moment in your career when was it that you had that aha moment of alignment, where it was sort of the light bulb went off and said, this is how I need to change our business, this is how I need to relate to the rest of the healthcare system. What prompted it, and what was that experience?
So I know exactly, like I've told this story a bunch, and so I'm glad to tell it here. So we had a patient walk in the pharmacy. My father and I were working that day. I could hear our technician say, sir, blah, 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 blah. So I went over and I said, Bonnie, what's going on? And she said, oh, this patient walked in with this prescription. We don't have it. And so I told them that we would have it tomorrow. Great. So the next day, what it ended up being was it was an HIV patient, small rural area. At the time, we weren't doing much HIV. We worked $4,000 worth of medicine. We didn't have it in stock, but next day delivery, we were going to have it, and no big deal. Next day, drug showed up. We were ready to go. Patient didn't show up. 2 weeks later, Dad looks at me and says, you got $4,000 worth of medicine on the shelf. Send it back. 2 days after that, guess what happens? Guy walks back in, wants his medicine. We looked at each other like we totally failed. We failed the patient, we failed our business, we failed their provider. Did we call them? Did we tell the provider they hadn't picked it up? We failed everybody. So we completely changed our entire practice based on that one singular event.
And for you, Dr. Wynn, did you have an aha moment at some point in your career trajectory? You said, practicing the way I started practicing, it's going to be tough if it takes a village. What was that moment, and how did it change? You say, I'm going to think about this differently, and here's what I'm going to do differently.
I'm not sure there was one moment. There were several things that made me think about medicine very differently, and a lot of them revolve around deaths of patients that were unnecessary. And there was a patient particularly that I remember that was trying very hard. She had a lot of psychiatric comorbidities, she had a lot of anxiety issues, and was very anxious to please. So she didn't tell us the whole story, why she's not taking this, why she's doing this, and that she was living on disability income and which barely covered her rent, left a few dollars for food and nothing for medications. And she had insurance, but couldn't afford the copays, and that we were shopping around for medications and trying to get things for her, getting samples for her, trying to manage that. And then we just, different pharmacists involved, and she just fell through the cracks. And we just were not able to help her, and that was very frustrating because the resources were there.
At that moment, you want to do pharmacy differently.
Oh yeah.
Essentially.
Yeah, there's got to be a better way to do this.
So tough question. The majority of healthcare in this country is purchased by two groups, employers and taxpayers. As a plan, our sense is that employers and taxpayers aren't particularly happy about how we not only set up the healthcare system, but in particular how we try to leverage our investment in medications, right? 'Cause, that's what we use medications for. They're a modality to prevent some downstream disease progression or poor outcome. What are employers and taxpayers telling you about how they want to see things different so that we create performance alignment, so that we create patient alignment? How do we create this alignment where we do care differently in a team-based model and so on and so forth? And what are they telling you as sort of a purchaser community?
Yeah, so all of us have a certain aspect of a business hat on, and we talk about return on investment. And really what we're looking at is a return on health, right? So the investment that we're making societally, plan sponsors that you mentioned, purchasers, employers, the government being the largest single purchaser of health, we're really looking on a return for that. We're looking for better health outcomes. We're looking for persons to be aware, so that notion of patient experience. And again, we're looking for affordability. So we look for what kind of value are we getting? And that's where we're really shifting significantly from pay for volume to pay for value. And how do we define that value? Again, that value is defined on total cost of care. So we look at a particular system. We would look at Dr. Wynn's practice and his 4.5 FTE, and would say to him, here's how you're doing with the persons that are in your practice. We call that attribution, so you have an attributed population. And then we look at how you're doing around key quality measures. Again, the measurement of quality is an imperfect science. We know that everything that is measured doesn't matter, and we know that everything that matters isn't measured. So we still are struggling there. But for what measures we do have and for what measures that are perceived as having a significant impact on a chronic condition like diabetes, we assiduously measure those things. And then we, again, look at how persons are experiencing their care. When I was hearing my colleagues talk, and I was thinking about the great work that they do and this notion of person or family or patient-centered care, it's not about us doing things to people, it's about us doing things with people. So, and one of my heroes, Dr. Berwick, talks about radical redesign, and he talks about changing the balance of power. That's such a powerful statement, such a profound statement. So again, it's not this paternalism, the pharmacist knows best, the nurse knows best, the doctor knows best, the health care CEO knows best, but rather what are you looking for, what are your goals? And similarly, what are your family's goals?